Hello, good evening, everyone. I'm Dr. Sonali Agrawal, IFS Executive Member of IFS MP Chapter, Gwalior. I welcome you all in this sixth webinar series of Polaris. This is a monthly unique webinar on imaging in gynecology and infertility. For that, I am really grateful to our hardworking, dedicated mentor, Dr. Bela Bhatt Madam and Priya Bhave Chittawar Madam. It's really my honor to invite our committed personality and ever-smiling, knowledgeable Dr. Bela Bhatt Madam. She is a lead consultant at Dr. Bela's Women's Hospital and Fetal Medicine Center, Andheri, Mumbai. She's fetal medicine consultant, Dr. Babasaheb Ambedkar Memorial Central Railway Hospital, Mumbai. She's FMF UK certified sonologist for the fetal abnormalities. She's FMF certified sonologist for nuchal translucency. She's Foxy certified trainer for ultrasound in obstetric and gynecology. She's author of book The Vital Skills, Ultrasound in Obstetric and Gynecology.
That's enough, Sonali. Yeah. No need to read the CV. At the outset, good evening and welcome to one and all to this wonderful series, Polaris series of webinar. I would first like to thank the FOGSI President, Dr. Jaideep Tang, Secretary General, Dr. Madhuri Patel, and the VP in charge, Dr. Girija Wagh, for always supporting the academic activities of Imaging Science Committee, FOGSI. And of course, I have to thank the two active and enthusiastic ladies, Dr. Priya Bhave and Dr. Sonali Agrawal, who put a lot of efforts to give shape to this series, Polaris series of ultrasound in infertility and gynecology. And we all know that this has been a very popular series because the topics and the speakers that we select are absolutely very, very useful topics and eminent speakers who are very knowledgeable in the field. Well, today we have started from the basics of ultrasound in gynec, and we have come to the sixth webinar of the Polaris series. And today we have none other than Dr. Supriya Sheshadri, who's going to teach us the tips and tricks of assessing a thick endometrium. And I'm sure everybody will carry a lot at the end of the webinar. And of course, Dr. Sonali Agrawal, along with expert Dr. Supriya, is going to conduct a wonderful panel after the talk. We are all very blessed to have the chief guest, Dr. Suchitra Pandit, here today with us. So welcome, Suchitra Pandit, madam. Well, the Suchitra Pandit, ma'am's CV is really exhaustive, but just to bring out some of the important points. Well, madam is, we all know, she is past president of FOGSI and ICOG in the year 2014-15. Currently, she is consultant department of OBGYN Surya Hospital, Mumbai. FOGSI representative to SAFOG from 2024 to 26, associate member of FIGO Ethics Committee, co-chair NCD Committee SAFOG, past president of ISOPAB, Gestosis India, chairperson of AICC, RCOG, president of Mumbai OG Society in 2013-14, and she is holding the post on so many national and international federations and associations. She has more than 130 publications to her credit, and she has authored 5 popular books also. And above all, I would like to say that Suchitra madam is a sweet, humble, simple person, and always there for academics, a brilliant academician. So welcome, ma'am. And we would like to start our webinar with your blessings.
Right. Thank you so much to a very dynamic leader, I would say, Bela Bhatt, and she's also an excellent dancer. Most of you would be knowing that. And she's conducted her committee of imaging sciences very, very well. And what I liked today was, this is a topic which is of great clinical importance. The thickened endometrium, how do you deal with it? And I think very rightly that when you're doing a webinar, you're reaching out to people. So in this case, the IFS MP chapter, I think that's a very, very important role that Priya Bhave is, playing along with you. So both of you together have joined up with the Bhopal as well as the Northeast societies. And it's good, now because of Foxy, we're able to reach out, because of Zoom, we're able to reach out to so many people, get their ideas. And maybe, there is sometimes some situations hand holding and giving some kind of, advice. And though we know you have guidelines coming in from, various international organizations, we have our own Foxy guidelines too. So therefore, very much in this context, I think your webinar is very, very relevant. And I see, some familiar names there, though I haven't seen their faces here. Sonali, of course, I've met, and I know Anita Srivastav, but I'm not able to see her right now. Anita Srivastav from Bhopal, as well as Anita Srivastav from Gwalior. And of course, then there is Shabana Sultan and there is Diganta. So it's good that, there's a combination from Bhopal as well as the Northeast. And you've got all these young panelists. And I know Purva Badkar from that. But the others I have not had the chance to meet. But it'll be nice to see what they have to say. And, let's get some consensus. Let's get some standard way of management. And this is what, your webinar is going to teach you, Bela. And I'm sure, at the end of the whole session, you will be giving some kind of a take home message. So that's going to be very, very important. And I also know that you're finishing your tenure in January. So all the best for your January outgoing workshop. And I also heard that you're contesting for the vice president elections. So best of luck for those elections too. And once again, thank you very much for inviting me. I would like to say congratulations to Neena Malhotra, who's taking over from you. I was with her at Hyderabad, and the results of the chairperson were going to be announced at 5 o'clock. But by that time, we were all in the flight, so I couldn't personally congratulate her. But if she's not yet reached, please extend my congratulations to her for taking over from you in the month of January. And once again, all the best, happy listening, and happy taking home some very, very important messages. Thank you so much, Bela.
Thank you so much, ma'am, for those kind and encouraging words to all of us. And it's really, really a blessing to have you here today. Thanks for sparing your time and giving your valuable time here today. And thanks for giving me blessings for Foxy endeavors as well. Thank you so much, madam.
Thank you.
Thank you so much, madam, for your lovely blessings and sparing your valuable time with us, ma'am. Thank you so much for your blessings. I think Dr. Neena Malhotra, madam, she got stuck with some meeting, so she won't be able to join. So,
Do we
madam,
see Dr. Girija Wagh, ma'am? Has she joined? If not, then whenever she joins, we'll just take
yes,
her.
yes.
Okay.
So, I would like to invite Dr. Priya Bhave, madam. She's a FNB reproductive medicine teacher, ex-faculty, DM reproductive medicine, Foxy organizing trainer in basic and advanced infertility. She's Cochrane reviewer, author. She's a secretary of MP chapter IFS. I welcome you, ma'am.
Thank you so much, Sonali, and I will not take much of your time because all of us are very, very eager to listen to Dr. Supriya ma'am. When we conceived this series, we named it Polaris after the pole star. So all of us know that all the navigators look at the pole star when they are navigating in the seas. So similarly, in our country, we have some eminent people who are like the last word in ultrasound. So one of them is Dr. Supriya, and all of us have learned so much from her over the years. And it is such a pleasure to have you, madam, to share your wisdom, your experience with all of us. Many of us have been your students virtually. So thank you so much for accepting our invitation and being a part of Polaris series. I would also like to thank Dr. Shikha from Northeast Chapter IFS. This time we have not only included Bhopal Society. So Dr. Anita Shrivastava madam is here. She is the president. And Dr. Shikha, she is the secretary of Northeast Chapter. So Shikha, we are really pleased and we are really thankful to you for your cooperation for this webinar.
Thank you so much, ma'am, for the opportunity. It's a pleasure. Thank you.
Thank you. Thank you, ma'am. And I would like Sonali to go on with the rest of the webinar.
Yeah, just before we start, I would like to thank Dr. Anita Srivastava from Bhopal G Society and Dr. Shikha. Welcome and entire Bhopal OG Society members. I welcome you all and thank you for joining hands with Imaging Science Committee as well as IFS MP chapter for this webinar. Thank you.
Thank you.
Thank
Yeah.
Very big thanks to all the stalwart joining here and blessing us. Thank you so much, madam. So move on to our first session. The topic of the today's webinar is thickened endometrium, the differentials of ultrasound by Dr. Supriya Shihadri, madam. For that, I would like to invite our esteemed chairperson, Dr. Anita Srivastava, madam. She is organizing chairperson VPCon 2020-24. She is the currently president Obstetric and Gynecological Society of Bhopal. She is postgraduate from Government Medical College, Jabalpur. She was gold medalist and university topper. She has been vice president and past treasurer of Bhopal societies and menopausal societies, trained in regenerating and cosmetic gynecology. She is senior consultant at Chirayu Health and Medical Private Limited, Bhopal since 30 years. She has special interest in routine obstetric, high-risk pregnancy, adolescent health, and cosmetic gynecology and midlife management committee. I welcome you, ma'am. Our next chairperson is Dr. Shabana Sultan, madam. She is professor and head Department of Obstetric and Gynecology at GMC Bhopal. She has organizing secretary of VPCon Foxy, presented many papers in national and conferences, published many papers. She is a member of esteemed team of PPH bundle along with the Sevagram. She is post joint secretary, past treasurer, and presently she's secretary of Bhopal Obstetric Gynec Society, executive member. She is special trained for gynec oncology and high risk pregnancy. She's a master trainer of cervical screening program also. Our,
Thank you, Sonali.
thank you so much, ma'am, for joining. Our next chairperson is Dr. Anita Srivastava, madam from Gwalior. She is faculty and master trainer. She's a State Institute of Health Management and Communications, Gwalior. She is joined MP Health Services in 1993, conducted 45,000 plus LTT surgeries, awarded for the doing highest number of LTTs in year 2015 and 16 and 16-17 and 23 and 24 by Health and Family Welfare Department, Government of India. She's ex-chairperson of PCP&DT Committee of District Gwalior, working as a member of District Quality Assurance Committee, developed multiple training modules and PowerPoint presentations. I welcome you, ma'am. Our next chairperson is Dr. Dignata Deka, sir. He is MS Obs Gynae from Guwahati Medical College, Senior Consultant Program Director, Gynecologist and IVF Specialist at W. Pratiksha Hospital, Guwahati, Assam. He is having 15 years of experience. So I welcome you all, the esteemed chairperson. Kindly introduce our today's eminent speaker.
Can I get the CV? Yeah.
Yeah.
So I welcome Dr. Supriya Shishadri, madam. She is trained in obstetric ultrasound at Fetal Medicine of India under Dr. B.S. Ramamurthy, 2004, consultant sonologist, fetal medicine and gynec US, member of ISUOG task force, scientific coordinator and faculty of OPUS Simulator, program director and faculty of gynec ultrasound program, expert trainer of simulator-based gynec ultrasound faculty for the Gynae US Marrow OB-GYN residency program, and faculty on simulator-based USG program. So I welcome you, ma'am, for your talk of thickened endometrium.
Thank you. Good evening and thank you all. I'm really overwhelmed with all the greetings and all the support, and I'm very, very happy to be here. So there's so many societies. So obviously your intention is to take women's health forward, and no better way to do this than holding these webinars. So congratulations, and again, all the very best going forward. Now let me share my screen. Okay, one sec, I just want to take this video off. Let's minimize this. Okay, can you see me?
Yes,
Can
ma'am.
you see the screen?
Your screen is visible.
Thickened endometrium differentials and ultrasound. Now, the background of this entire talk is based on IITA. IITA is International Tumor Analysis Group. They were actually founded in 2008. And all along, at first, they were just describing the terms, definitions, and measurements. And then they did an analysis of what lesions we see when there is abnormal uterine bleeding, when there is no abnormal uterine bleeding in the postmenopausal group. There are a lot of articles from them. And I think it's very, very good to refer to them. And this, I use them hugely in my practice as well as in my talks as well. So thickened endometrium is an objective finding and not a subjective finding. For this is a short clip. As you can see, this is the sagittal section of the uterus. I call it sagittal because there is a continuity of the cervix with the endometrium. I have made the endometrium as horizontal as possible because we know that on ultrasound, if you need to see anything well, that has to be perpendicular to ultrasound beam. And once I get the endometrium horizontal, then I am going to magnify it, which I've already done. And the measurements that I'm taking is an outer to outer. So again, to repeat, sagittal plane of the uterus, endometrium perpendicular to the probe, magnify the image, measure the thickest portion, do not include the EMJ or the endomyometal junction, measurement to be recorded in millimeters. One can do this even on a abdominal scan of the endometrium. And these are the two images because ever so often we hear this criteria saying measure 1 to 1.5 centimeters below the top end of the endometrium. Not really, because one needs to measure it at the widest part. And as you can see at this image, the widest part is almost the mid portion of the endometrium. Now, what is not correct to be taken as endometrial thickness is images and measurements like this. Now, this is, yes, the sagittal plane, but this is not a magnified image. This is, in fact, a coronal plane, which we do get sometimes because the uterus is insonated in such a way that we get coronal planes of the uterus. How do I recognize a normal endometrium in a sagittal plane will be a leaf-like, whereas if we get a triangular-shaped endometrium, then that indicates that it is a coronal plane, and that is not standard. So my first message here is anytime we see a report saying thickened endometrium, please look at the image. There should be images accompanying every report. I mean, that need not be emphasized enough. And in that image, if one sees a triangular endometrium, then we know that this is an erroneous measurement due to the position, and this definitely is not what it actually is. Now, sometimes I see measurements of the endometrium made in a transverse plate. This again is an incorrect way of measuring the endometrial thickness. When there is pathology, there are certain variations in how we measure the endometrium. When there is endometrial fluid, IITA recommends that we take what is called the single layer thickness. We do not go across the fluid, take the single layer thickness on either side and then add it up, and that will give us the endometrial thickness. When there is a polyp, we go across the polyp because obviously that area will become the widest portion of the endometrium. And since the polyp is endometrial in origin, we include the polyp in the measurement. However, if we see a fibroid polyp is not endometrial in origin, and therefore one should take the endometrial thickness away from the polyp wherever it is maximum. And in a scenario like this, wherein this is adenomyosis, wherein the EMJ is not well seen, the borders of the endometrium is not well seen, IITA says write non-measurable, but I would think that if I wrote that, someone would think that I don't know how to measure. And so in these cases, what I do is I write there, EMJ not well seen, endometrium not well defined. However, approximate measurement is so and so. Now, how thick is thick? In the premenopausal, there is no consensus on the endometrial thickness cutoff. These authors have said that in premenopausal women with or without abnormal uterine bleeding, an optimal cutoff for the ET has not yet been established. Therefore, the routine use of ET alone is not recommended to confirm suspicion of endometrial cancer or precancerous lesions. These authors said that normal endometrial thickness varies widely in the premenopausal population. The Royal Australian and New Zealand College, they opined that suggest endometrial biopsy when the thickness is more than 12 millimeter in premenopausal women and more or equal to 5 or in cases of anovulatory AUB. Then what about the group of premenopausal? This study was done on 849 women. The median age was about 38 years. 70% of them had normal menses, 5% were amenorrheic, and the rest had poly and oligomenorrhea. These authors found these measurements. That is, in all women, the 90th centile for thickness was 13.8 millimeters. The 95th centile was 15.8. If measured in the first half of the cycle, the 90th centile was 11.8 and the 95th centile was 13.2. In the second half, the corresponding were 14.2 or 16.5. Therefore, they said that a cutoff of more than 16 millimeter in the secretory phase when it is homogeneously thickened should be used. Now, coming to the postmenopausal group, again, two categories here. With bleeding, there is no consensus on the thickness cutoff. This chart shows the various sensitivity and specificity at the different endometrial thickness measurements. And what can be seen as 3, 4, and 5 have almost the same sensitivity and similar specificity. Now, practically, most people use 4 millimeters, some use 5 millimeter. I would think it depends on the order of your findings because the point is to keep the false positives very less. Lower the cutoff, lower the rate of false positives. But I think practically most people use either a measurement of 4 millimeter or 5 millimeter in their practice. Now, what about the group, postmenopausal group without bleeding? Again, there is no consensus on the thickness cutoff. Some authors use more than 8 millimeters, some use more than 10 millimeters, and some use more than 11 millimeters. Now, this is a chart showing the sensitivity and specificity of the various cutoffs. And as we can see, 8 millimeter has got good sensitivity and specificity, and therefore that is, again, traditionally used. But 11 millimeter is what is popular in the Western world. Another group of authors who did a systematic review and meta-analysis opined that endometrial thickness measurement has no value in this population, that is postmenopausal group without bleeding. So practically, I collated this algorithm and it worked for me, it works for some others, and I hope it works for you as well. In the premenopausal with abnormal uterine bleeding, cutoff is more than 12 millimeter. Without AUB, it is 14 millimeter in the proliferative phase. In the secretory phase, it is 16 millimeter. In the postmenopausal group with bleeding, again, 3, 4, 5, but I think 4 and 5 are the most popular measurements taken as cutoff. And without bleeding, anywhere from 8, 10, or 11 millimeter. But the story should not end here. One should look beyond the thickness. The causes for a thick endometrium are endometrial carcinoma, endometrial hyperplasia, endometrial polyp, submucous fibroid, endometritis, as well as an anovulatory endometrium. Now, as we can see, there's a huge overlap in the measurements in all these categories, and that's why it is said, look beyond thickness, which means we need to look at the morphology of the endometrium, and Aita has laid down these points. So we look at the endometrial echogenicity. Next, look at the endometrial midline. Look at the EMJ. Note the endometrial vascularity in two ways. One is a color score, and the other is a vessel pattern. So let's look at each of these morphological categories one by one. Coming to echogenicity, again, two categories, uniform or homogeneous and non-uniform So in uniform homogeneous, we get a this is to be called a hypoechogenic as per Aita, and this we all know is the triple line endometrium. This is an isoechogenic and this is a hyperechogenic. Now for the newcomers here, when I say new, those are new to ultrasound practice, how do we actually say hypo, iso, or hyper? Is when we compare the echogenicity to the surrounding myometrium. And therefore, with this background, you'll easily understand why these are labeled as such. Also, it's important that the endometrium should be symmetrical, anterior and posterior. Coming to the non-uniform category, one is the heterogeneous. Second is cystic, wherein we see these anechoic spaces. You can have a single space, multiple space. You can have large space, small space. You can have regular or irregular. All that will put this endometrium into the category of a cystic endometrium. And this is an asymmetric endometrium, which is normally seen in Asherman's, wherein I see the endometrium appears pinched off. Next, coming to the midline. This is a normal midline wherein it is linear or continuous. The interrupted is, this is a case of RPOC where the midline is interrupted. This is a fibroid polyp where it is interrupted, and again, an endometrial polyp is interrupted. AITA is some other terms where they call it irregular or a non-linear midline. But we don't really see that so common in practice. What we normally see is an interrupted midline, and that will tell us that there is something inside the cavity, because the midline, why is the midline there? The midline is there because in ultrasound, anywhere in the body, whenever two mucosal surfaces meet, they cast a white line. So this hyperechoic line that we see is because of two endometrial leaves or two portions of the endometrium coapting or touching one another, and therefore causing that white line. Coming to the endomyometrial junction, this can be seen on 2D as well as a hypoechoic halo surrounding the endometrium. This should be noted in all planes. However, this is well brought out or better brought out in a 3D. Now, this is an irregular EMJ seen on 2D as well as 3D. And this is what is called an interrupted EMJ seen on 2D as well as 3D. Coming to the last category, endometrial vascularity, we look at it in terms of color score. This color score is very similar to the IOTA classification and terminologies of the color score, which means it's a subjective, semi-quantitative assessment. So when there is no color at all, it is color score 1. When we look hard and we see a few specks of color, that's color score 2. Color score 3 comes between color score 2 and 4. 4 is abundant color, wherein even a beginner to ultrasound will be able to say that there is an increased amount of color. So between 2 and 4 is color score 3. Now, when we assess the endometrial vascularity or want to note the color, it's important that we optimize the Doppler. There are several steps in optimizing the Doppler, but what is important to note is, first and foremost, in gynae studies, in gynae vascularity studies, we use what is called the power Doppler, because power Doppler has got the ability to pick up low velocity flow. In gynae, whether it's abnormal or normal, it's always very small vessels and low velocity flow, and therefore it's recommended that use a power Doppler. Power Doppler also does not have the disadvantage of aliasing. It is not angle dependent too. Adjust the gain of the power Doppler just as we would adjust the gain for a color Doppler. And when we do not see color, then go to this button called the PRF, or sometimes called the velocity scale, and bring down the PRF to 0.3 to 0.6. So only when we have adjusted the gain and adjusted the PRF will we see what the color or color score is. Another useful practical point is, initially when you're beginning to recognize what the color score is, it's good to turn up the gain so that you will see color everywhere, what we call color noise or color artifacts. Then turn down the gain till you do not see color. Right now, my interest is the endometrium. So I would have turned down the gain till I do not see color, and then I will increase the gain. But practically what works for me is, if I were to take a pencil and outline each vessel, that to me is a correct color gain, and that is what I will use to assess my color score. Coming to the various categories, the commonest is the thick endometrium due to anovulatory cycle. Here, again, the measurement can be anywhere from 6 to 13 millimeter. It is what is called homogeneous hyperechoic. Now we know what the meaning of these terms are. The midline is linear. We know this as well. EMJ is regular, color score 1. We know this too, but this is seen only in 55% of cases. And the vessel pattern can be absent or non-specific. Now, the second point, as I told you earlier, in endometrial vascularity will be to look at the vessel pattern. And that I will be telling you as we go across the different pathologies. Endometrial polyp is something that all of us will come across more than once. Now, what is it? It's a localized overgrowth of endometrial tissue, which occurs secondary to an increased estrogen or chronic inflammation. It's composed of glands, stroma, and blood vessels, and it can be covered by epithelium, which is secretory, proliferative, or even hyperplastic with or without atypia. It is seen in 10 to 40% of symptomatic women, the most common symptom being an abnormal uterine bleeding, 12% are asymptomatic women. In the premenopausal group, the incidence is 5.8%, though I would say that I think in our scenarios, we see much more than just 6%. And in the postmenopausal, it is around 12%. The symptoms do not correlate with polyp number, size, or site. How does it look, or how are we to report the findings that we see in an endometrial polyp? First is the thickness, which again has a wide variation, anywhere from 8 to 14 millimeter. The echogenicity is homogeneous or hyperechoic. It can also be heterogeneous. It can be cystic. Now, cysts are more commonly seen in the postmenopausal group. Cysts are due to fluid collection in the glands. The midline is interrupted in the premenopausal group, not seen or what is called undefined in the postmenopausal. Now, this is a postmenopausal endometrium, this is a premenopausal endometrium, and these are the findings as I'm describing it. The EMG is always regular. The color score can be anywhere from 2 or 3, and the vessel pattern is what clinches the diagnosis. It is said to be a thick, dominant vessel because these blood vessels are thick-walled when studied on histology, and even on ultrasound, they appear very thick. Now, this vessel may branch or may not branch. And if it branches, usually there's 1 or 2 branches. If there are more than 4 or 5 branches, then suspect atypia in the polyp. This feeding vessel is called the pedicle artery sign, or even or the feeder vessel. Sorry. When we look at polyps, sometimes if you look at if we are evaluating the lady in the secretory phase, as you can see in this image, this lady was 28 years old, had a history of intermenstrual spotting for 3 months. She came first on day 22 of the cycle, and day 22, I would call this a heterogeneous endometrium. Of course, I always have the Doppler to fall back on, but we all, or some of us have been through scenarios where the Doppler settings are really pathetic and we can't get the best of the Doppler out of the machine. So in those cases where we cannot decide is this a polyp or not, then we will call her back on the day 10 or day 12 of the cycle. This is because around day 10 to day 12, the endometrium is thick enough. The endometrium is hypoechoic because it's a triple line endometrium. Therefore, the polyp, which is hyperechoic, stands out well against the hypoechoic endometrium. And that's why it's recommended that when one wants to assess for a polyp, it is best to scan her between day 10 to day 12. Another very, very useful sign in polyp is what is called the white line sign or the bright edge sign. This again easy to understand. Why is the white line there? Because 2 mucosal surfaces are coapting. Now, what are the mucosal surfaces? One is that of the endometrium and the other is that of the polyp. And this white line sign, in fact, comes to our aid a lot of times. And when we put on color, there will be a feeder vessel here. Polyp can be benign or malignant. It can be single or multiple. Multiple polyps are seen in 20% of cases. They can be small or large. They can be sessile and pedunculated. 27% of them regress at 1 year. And therefore, if the lady is asymptomatic, there is no need to do any surgery for her. Also, watch or conservative management if the size of the polyp is less than 10 millimeter. However, if the size is more than 15 millimeter, then regression is less likely. Incidence of malignancy has been variously quoted, or malignancy in the polyp has been variously quoted as 0.5 to 4.8 to 12%. The base or stalk of the polyp must be benign and the surrounding endometrium must be free of malignancy to call it that malignancy is present in this polyp. Of course, this is a histological finding. The prevalence of hyperplasia with no atypia is 25.7%, and the risk factors for developing malignancy in a polyp is the age, abnormal uterine bleeding, obesity, postmenopausal age group, hypertension, diabetes mellitus, or tamoxifen use. The risk of malignancy is the same whether the lady has symptoms or not. And another clue is when on a pap smear we get atypical granular cells, then it is said that the incidence of endometrial polyp in such cases is in the range of 3.4 to 5%. Now, when will we suspect hyperplasia or malignancy in a polyp? When the polyp has an irregular outline. Sometimes, if we're seeing it closer to ovulation, we might see ovulatory fluid. Else, SIS will help us to define the outline of the polyp. And if it is an irregular outline, then that is again a clue to hyperplasia malignancy. Or, as I said a little earlier, when you see more than 4 or 5 branches in that single vessel, or when we see a multi-vessel pattern or a scattered vessel pattern, then that again is a clue to hyperplasia in the polyp. And RF 0.5 is another finding that has been reported to indicate that there may be malignancy or hyperplasia in a polyp. According to Devo, in the study in 2021, he said that polyp size, patient's BMI, and intralesional cystic spaces were the best discriminators between benign and pre-malignant and malignant polyps. No cases of pre-malignancy or malignancy were seen when the BMI was less or equal to 28, polyps that measured less than 13 millimeter mean diameter, and when there were cystic spaces. And in those women whose BMI was more than 28, polyps more than 13, and what they call solid polyps, which means no cystic spaces seen, 2/3 of those polyps were found to harbor some malignancy. The risk of malignancy increases over 50 years, and over 60 years, the risk can be as high as 2.4 to 2.8. The differential diagnosis for an endometrial polyp will be a submucous fibroid or a fibroid polyp. Here again, thickness, I mean, as you see from all these pathologies, thickness really has no value, and therefore we should not stop, again, repeat, not stop at just saying thickened endometrium in our reports. What is the ecosystem submucous fibroid? It is homogeneous, hyperechoic, that is, there's sometimes when there is a lot of fat content in the fibroid, we will get a hyperechoic fibroid, or it is heterogeneous. But in practice, most often we see what we see is hypoechoic. Therefore, again, the best time to pick up a submucous fibroid if one is not used to SIS is in the luteal phase, because in the luteal phase, the endometrium is hyperechoic, the fibroid is hypoechoic, and therefore stands well. Here, the midline is not defined in the sense it's interrupted. The EMG is also interrupted. You can get a color score of 2 and 4, but what is the clinching feature for diagnosis is this circular flow or this peripheral vascularity, which we all are very, very familiar with when it comes to the diagnosis of a fibroid. The next pathology that can show up as a thickened endometrium is endometrial hyperplasia. Now, this is a precancerous, non-physiological, non-invasive proliferation of the endometrium. It's a histological diagnosis. It results because of unopposed estrogen effect on the endometrium. WHO has put it into 2 categories. One is with atypia and the other is without atypia. It can coexist with endometrial carcinoma in 40% of the cases. Cases of endometrial hyperplasia may be asymptomatic, but quite often they're present with abnormal uterine bleeding. They usually are seen in perimenopausal women. However, 5% occur at less than 40 years of age. They may be an incidental finding on ultrasound, as I said, asymptomatic totally, or on the pap smear, one gets to see abnormal endometrial glandular or stromal cells. Endometrial hyperplasia on ultrasound shows up in various ways. One and most common is cystic endometrium. To repeat, cystic endometrium is when I see anechoic spaces inside. The other is what is called a uniform hyperechogenic endometrium or a heterogeneous endometrium. And in all these cases, the midline is not seen. The color score may vary. And the pattern here is what is called a multiple vessels with multifocal origin, in the sense, if you can see in this image, if you can make out in this image, you see parallel vessels crossing the EMG and entering the endometrium. On the other hand, you see the specks inside the endometrium. So this is called the scattered vascularity. There may be a color score of 1, which means no flow at all. So 1 or 2 go in favor of without atypia, and a color score 2 or 3 is in favor of endometrial hyperplasia with atypia. The other presentation of endometrial hyperplasia, which will be what is called a polypoidal endometrium. Now, I know there's some ambiguity in these terms, but popular literature says polypoid is not multiple polyps. Then what is polypoid endometrium? Again, under the influence of estrogen, the endometrium forms folds. And the way to differentiate this from a polyp is in polypoidal endometrium, the midline will be continuous. Now, sometimes we see this pattern even in the secretory phase. In the secretory phase, sometimes we even see these spiral vessels parallelly crossing the EMJ and entering the endometrium. So in those cases, how to differentiate endometrial hyperplasia from just a secretory phase? Follow back in the proliferative phase. If there's endometrial hyperplasia, then you will see this either a cystic or a heterogeneous endometrium or even a homogeneous hyperechoic endometrium with this multivessel pattern or a scattered pattern. But yes, polypoid endometrium can be a manifestation of endometrial hyperplasia. And therefore, before just dismissing it as a secretory phase endometrium, one would think that there would be a role for endometrial biopsy in such cases. When there is endometrial hyperplasia, like this is again polypoidal, and we see these multiple vessels crossing the EMG, entering the endometrium, what is called multiple vessels, multifocal origin. Always look for the source for the excess estrogen. Very often is polycystic ovaries. Sometimes we see what is called a functional cyst or a simple cyst in the ovary. Now this again could be the source of estrogen, and that's why this endometrium has the appearance suggesting that there could be hyperplasia. The next category, which we all are very about and which we should be watchful for, is endometrial carcinoma as a cause for the thickened endometrium. This is predominantly a disease of postmenopausal group. However, 5% is seen in less than 40 years of age. It is diagnosed usually early and therefore it's good prognosis. The diagnosis usually early is because most of them manifest with abnormal uterine bleeding. The incidence in Europe is quoted to be 14.7 per 100,000 women. In India, is 4.3 per 100,000 women. It is said that more than 90% of women with endometrial carcinoma present with postmenopausal bleeding, but over 90% of women with postmenopausal bleeding have a benign underlying cause for their symptoms. So what are the ultrasound manifestations? Normally a very thickened endometrium. Even we never see, going up to 26 in the other categories. The echogenicity can be heterogeneous, with or without cysts, or they can just be an irregular focal lesion. Very often there's pyometry as well, and that's why we're able to appreciate that there is a local lesion and the surface is not smooth. Here the midline is not seen and therefore called undefined by IETA. The EMJ is interrupted in 42% of cases, and the color score is high, that is about 3 or 4. Two patterns again, here is called multiple vessels of focal origin or multiple vessels of multifocal origin. You can have either of these two patterns when it comes to endometrial carcinoma. Ultrasound can also tell us whether it's low risk or high risk. Now, these were the findings by Elizabeth Epstein. Sorry for the pronunciation. The low risk category is where the thickness is less or equal to 13. High risk is 15 to 28. EMJ is regular in the low risk, irregular in the high risk. Uniform echogenicity in the low risk, non-uniform in the high risk. A color score of 2 in the low risk, color score 3 or 4 in the high risk. Vessel pattern, single branching or multiple vessels with focal origin. And a high risk is multifocal vessel pattern. Low-risk cancers are defined as stages 1A, grade 1 to 2, and high-risk endometrial cancers are grade 3 or non-endometrioid tumors, or those more than stage 1B. This is a good algorithm, although quite old, 2015 still works very well, wherein we can have a scoring system to tell us whether there is really a risk of endometrial cancer or not. For this, we need to know the BMI of the patient. Endometrial thickness 10 millimeters is one category. Endometrial thickness more than 15 is another category. Then we have vascularity, but no single or dominant vessel. Multiple vessels, large vessels, densely packed vessels, interrupted endomyometrial junction, and irregular endometrial outline. So each of them have a point of 1. When added up, if there is 3 or more, then the likelihood of that finding being an endometrial cancer is 90%. However, it should be borne in mind that type 2 endometrial cancers such as uterine papillary serous carcinoma, clear cell carcinoma, and other high-grade endometrial carcinomas are more likely to be found in women with a thin endometrium. This is a very nice study depicting how color or assessing color helps. This was done on 223 patients with postmenopausal bleeding, all of them with a thickness of more or equal to 4.5 millimeter, and they used 2D power Doppler. So here they studied the endometrial vessel pattern and assessed it for risk of malignancy. When there's irregular branching, the risk is 11-fold. When there's multiple densely packed vessels, as you can see here, it is 4-fold, and color splashes, which means you just see blobs of color. That means this is associated with a 4-fold increase risk of endometrial cancer. This is another useful scoring that can be done, simple as well. This is only using the Doppler parameters and not BMI, not the EMJ, or not the surface of the lesion. So when we look at vessels, if there is a vessel, but no single or double dominant vessel, then it's a point of 1. Multiple vessels, again, 1 point, large vessels and densely packed vessels or color splashes. So here they give a score of 2 or a cutoff of 2. And when they use this cutoff, that is score of 2, they found that endometrial cancer could be correctly identified in 81% of the cases. So what's the difference really, or how would we be able to tell on ultrasound whether this is hyperplasia and carcinoma? Actually, no, we can just say that likely, because ultimately this is all a histological diagnosis. But likely that is a hyperplasia is when we look at the thickness, increased thickness, almost going up to 20 and more, it's carcinoma. Coming to echogenicity, you'll never get a homogeneous hyperechoic in a carcinoma. And EMG is interrupted only 50% of times in carcinoma, where it is most often regular, and I would say almost always regular in hyperplasia. Color score, a high 3 or 4 is in carcinoma. Scattered pattern is hyperplasia, and multiple vessels. Focal origin is, again, diagnostic of carcinoma, not hyperplasia. The other category we see of a thickened endometrium is endometritis. Here, the endometrium is heterogeneous. The midline, again, is not seen. The EMJ is irregular or hazy because of edema. Color score 2 or 3, and vessel pattern non-specific. So in summary, thickened endometrium should not, I've only addressed thick endometrium in the non-pregnant category. So coming to the take-home messages, a report should not stop at thickened endometrium, nor should the line be included saying to be clinically correlated. The thickness should be taken at the widest anterior-posterior diameter in the sagittal plane of the endometrium. There is no one universal cutoff, be it premenopausal or postmenopausal. However, the cutoff that works is a premenopausal with AUB more than 12 millimeter, without AUB first half of cycle 14 millimeter, second half 16. So it's like 12, 14, 16. Postmenopausal with AUB 3, 4, or 5, and without AUBs 8, 10, 11. Look at the whole picture. Apart from thickness, look at morphology and look at vascularity as well. So these are images. This is what we call a homogeneous hyperechoic endometrium, cystic endometrium, heterogeneous endometrium, again hypoechoic or heterogeneous endometrium. So when we use power Doppler in order to know what is what, this is what we get. A homogeneous endometrium with a color score 1 is anovulatory. Multiple vessels, multifocal origin makes it hyperplasia. Thick dominant vessel makes it a polyp. Peripheral vascularity makes it a fibroid polyp, and a disorderly, that is irregular branching or very densely packed vessels makes it a carcinoma. But the final word where thick endometrium goes is this. In women with AUB and at a high risk for malignancy, be it either hyperplasia or carcinoma, consider endometrial biopsy regardless of endometrial thickness and morphology. So what are the risk factors? One is age more than 40, obesity, nulliparity, family history of gynae malignancy, polycystic ovarian syndrome, type 2 diabetes, chronic hypertension, and atypical glandular cells on pap smear. Thank you very much for a patient listening.
Thank you so much, madam, for your excellent presentation. I think you covered each and everything, and it is crystal clear also. For any queries, I request everyone to kindly write in the chat box, and we'll discuss later on. Thank you so much. Any other chairperson want to add something? Dr. Anita, madam. Ma'am, it was really wonderful, amazing lecture as always.
Thank you.
I really congratulate to you. You have covered each and all points, minute points and everything in your lecture. Thank you so much, madam. Priya, ma'am.
Really, ma'am, it has made it so crystal clear that I think all of us who have attended this, we'll go back with really very clear ideas as to when to, decide when to take a sample and how to interpret. I would also like any other senior members. Diganta sir is there, Dr. Neetu is there. If you have any comments or any doubts, we can ask Madam directly.
It was an excellent talk, actually. So almost everything has been cleared. So I don't think the junior will have any difficulty in understanding the whole topic, especially.
Thank you.
Thank you so much, all the esteemed chairpersons and wonderful lecture, ma'am. Thank you so much, Supriya ma'am, for the
Welcome, Sonali, and everybody
you.
else.
So,
Sonali, I think you can see the chat box. One query is there, or Madam can directly.
Where's, I
cannot
can't see. Can you
find
just read it out to me, please?
Yeah.
Where is the chat? Okay, there are 7.
I can see if ET is more than 14 mm in HRT cycle.
HRT is 4 or 5. See, again, I think we should just get out of a mindset of having thickness. Look at the morphology. And it is also said that if the morphology appears normal, then you can counsel the lady to maintain a calendar for bleeding. And if it is repeated episodes, then she should be investigated. No more relying on ultrasound.
Right. I think that's it. So thank you so much, madam.
Most welcome.
So ma'am, you be there as a
Yeah,
expert in the panel. Yeah.
Sure.
Move on to our next session, that is panel discussion. For that, I would like to invite our esteemed panelists for that, Dr. Neetu Mishra. Mr. Karan, can you display the CV? Yes. She's Associate Professor, Department of Obstetric Gynec, AIMS Bhopal. She's a winner of this ECMAR Meet Annual State Conference in 2012. She is MS Signature Award in 2022, and she has presented many papers and publications. Dr. Shushruta, I think she is not joined, and she was stuck with some some emergency. Dr. Shweta Agrawal, she is director of Ashoka IVF Care Hospital. She's founder member of CGISA's co-treasure Bhopal Obstetric Gynec Society. She was faculty Yuva Foxy. She is invited faculty in various conferences, and she's written many chapters in books. Next is Dr. Shikha. She is currently secretary of IFS Northeast chapter. She's presented many papers in national and international conferences. She has 9 publications and national and international journal awarded with Roberts G. Edwards Prize for Paper Award for being a best paper. She's a winner of Isar Ashram National Quiz for Clinician, and she is a winner of Leelavati Salvan Book Prize AIMS 2014. I welcome you, ma'am. Dr. Purva, she is currently working as Assistant Professor, Department of Obstetric and Gynaecology, Gandhi Medical College, Bhopal. She's a training experience of 8 years, national accredited trainer for the ISCCP colposcopy training courses, presently divisional convener in MPSC Agoy. Next is Dr. Battiston De Cruz. He is consultant at Macronian Medical Center and consultant at Manda Clinic, Shillong, visiting consultant at Bethany Hospital, Shillong, visiting consultant at Pratiksha Hospital, Guwahati. Our next panelist is Dr. Kalpana Jain. She's consultant at Birla Fertility and IVF, Guwahati. She's MS, FMAS, and DNB. She has done fellowship in reproductive medicine, Vapi, Gujarat. She's having 10 years of experience. So I welcome all my panelists. I'll share my screen.
Thank you, Dr. Soon.
Yeah. Give me a minute. Let me share. One. Share. Supriya ma'am, you have disconnected your this thing?
Yeah. Do you want? Okay. Is it okay now?
I think, yeah.
Your slide, your screen is visible, Sonali.
Okay, ma'am.
Yeah, it's
Give
visible.
me a minute.
Yeah,
Right.
no problem.
Okay. So move on to our. Okay. So here's our first question. 49 years patient, previous cesarean, 35 years old male, menopause in 17 years, came with a complaint of postmenopausal bleeding since 15 days. Complaint, a known case of hypothyroidism on medication. PS, PAPs taken, ultrasound is as follows. Give me a minute, I think give me a minute. I think it's not working.
I think just click on it, Sonali, it will work. Click on the start button.
Let me check. Give me 1 minute. I'm extremely sorry for that.
Yeah, it's seen very nicely. Just click on that lower button, I think.
Yes, yes. Okay.
Yeah.
I think that full screen is not.
No problem. We are able to see in this way also. No problem.
Yes, sir, no. So this is the TVS view. Dr. Shikha.
Yes.
Can you comment on this ultrasound picture? This postmenopausal patient with a thickness
So,
of 13 mm.
So this picture is this ultrasound is showing a thickened endometrium, as you have said, the thickness 13 mm, and it is a little heterogeneous in ecotexture, slightly hyperechoic, and on the
So
as much
what?
as I can see, the EMJ looks regular only, not so irregular,
Right.
and mild cystic spaces here and there, minimal are there.
So what you will like to do further in this case?
Yeah, since this is a case of postmenopausal bleeding, na,
Right.
along with thickened endometrium, I would like to go directly for a hysteroscopy guided biopsy. Hysteroscopy and endometrial biopsy.
Okay, right. So here's the color Doppler picture of this patient. Dr. Purva,
Yes.
would you
The-
like to comment on this?
Yeah, the color flow in this is around is not much of the vascularity is seen, but yes, it is score can be 1 or 2. Color score can be 1 or 2. Yes.
May I,
Yeah.
Doctor?
Yeah, Dr.
Because
Neetu?
it is showing, on color Doppler, it is showing the feeder vessels here.
Yes.
Yeah, in
Feeder
the
vessels are seen. So
endomyometrial junction.
most probably it is polyp. And as it is postmenopausal female, the chances of having malignancy in this polyp is high. So the next question was whether to go for MRI or SIS. So directly we can go for hysteroscopy and take the biopsy, or do the polypectomy and send the sample for histopathological examination. No need for MRI or SIS to rule out, because it is TVS is equally showing that there is feeder vessel, and even if we do SIS, it will only tell ki it is polyp or not. So in any ways, we have to go for hysteroscopy. So directly we can go for hysteroscopy and do polypectomy and send the sample for histopathology to rule out malignancy. And if there is malignancy, then we have to do all the workup in that female and go for a complete surgery.
Right. Supriya ma'am, would you like to?
Yeah, I mean, I'm mainly talking from the ultrasound perspective.
Right.
Again, it's always good for us to go back to basics. Now here I would keep my color box very small, just around the endometrium. Second, I would make the endometrium as horizontal. So when the endometrium becomes horizontal, the vessels become parallel. So we will be able to see color only when we make the endometrium horizontal. So I'm really not sure if it's a feeder vessel, and plus I can't really
It's a
make
multiple.
out. But yeah, I can't make out, but I would also pay attention to PRF. Now, if the PRF
Right.
is more than 0.6, I'll certainly bring it down, because there is a chance that when I bring the PRF down to 0.3 or 0.6, then it may show up more color. Now, going by the fact that all these things have been done, the Doppler has been optimized. If it is, yes, a feeder vessel, then I would think in terms of polyp. If it's not a feeder vessel, I would. So here, actually, the message from what I've seen is, when there is a cystic space in a postmenopausal endometrium, even if it's a single cystic space, think of polyp unless proved otherwise. Presence of a cystic space, more likely that this polyp will not be malignant, will be benign. Of course, there are the other factors also to be taken into consideration.
Exactly. So first of all, it's not a optimal color Doppler, and we can see scattered blood flow in this also. And we did a hysteroscopy for this patient, and taken this having a very vascular mass arising from anterior wall, and the uterine cavity was like not very healthy, and we can see one ostia here. So it's a, and then other side was okay, but this vessel was very vascular and originating from anterior wall. We took a biopsy of this patient and came to be endometrial adenocarcinoma. So this is the like postmenopausal patient with the cystic spaces with scattered and prominent vessel. We should suspect the polyp which is having malignancy potential. So move on to our second question. 50 years old patient, known case of diabetes mellitus with hypertension on treatment. She's menopause since 10 years, came with a complaint of postmenopausal bleeding since 1.5 years, on and off every 6 months. And endometrium was 17.6 mm. This is the Dr. Shikha.
Yes, this is a ultrasound is showing a thickened endometrium
Right.
with multiple cystic spaces, and it is inhomogeneous. Even though the myometrial junction does not look interrupted, and it
Right.
is. Yeah, I would
The
also.
cystic spaces are more pronounced in this case than the previous.
Yes.
Right. Dr. Shweta. Yes. There's no uniformity in cystic spaces. Some are large, some are small. It's not
They are more scattered.
scattered. So definitely would see the
Color flow.
color flow,
Well,
just showing intralesional vascularity in this patient. Really very
again,
sorry.
the scattered
My
vascularity.
screen, it's not working. I just so here is the hysteroscopy picture. This is the mass. It was which is coming again from the fundal part and posterior part. Here's the ostia. And we did a removal of this hysteroscopically and then send it. You can see the vascularity in this space. And sent for HP, it was showing the endometrial polyp with metastatic changes. So
It is metaplastic.
metaplastic changes in this. So whenever pattern flow is not good, we can suspect in postmenopausal with symptomatic patients, suspicious of endometrial malignancies.
Here, I want to add just for postmenopausal female, if it is thickened endometrium, we should always go for hysteroscopy and biopsy to rule out malignancy. And if it is polypectomy is done, and if it comes out to be benign, it is a complete treatment, but she should be kept on follow-up.
Right.
And if it is malignant, then we should go for. For postmenopausal bleeding, it is not it is very much clear that we have to do hysteroscopy and biopsy whenever we see a thickened
endometrial sampling is must
is very
to rule out adenocarcinoma of endometrium.
I would like to add simple DNC or just taking a random sample of endometrium is not work. Actually, we should.
But actually, this is the recommendation is that there is no difference between the endometrial sampling has to be done. It's not necessary the way which is done. It is compulsory to do, but more promising is the hysteroscopic biopsy.
Right. That exactly the point. Hysteroscopy, you are looking and then taking a
Yes.
sample. Sometimes we have seen many of cases like in a growth, there is a sloughing or a very superficial necrosed part. If by chance doing the blind DNC and taking that sample and it won't show anything. So it's
Yes.
better to
Under
take
vision
this
biopsy
yeah,
is
under vision
better.
biopsy.
I would
This
just
is
like to add one point, small point.
yeah.
So when we have in a postmenopausal women, like if we have a polyp, we have to remove the polyp as well as take the endometrial
Yes,
curettage
correct.
otherwise also.
Yes, actually.
Right, exactly.
Curettage is must.
Here. So this is the next question. 30 years patient, married since 7 years. Gravita 2 previous full-term cesarean section 5 years back, followed by DNC 1 year back of 2.5 months, like 1.5 months missed abortion. Then followed by secondary amenorrhea since 1 year after DNC. And now she is secondary infertility, wants issue. Sorry, I am not able to display the pictures. So directly I'm going for this is the ultrasound picture of that patient. Dr. Shekha, are you there?
Hello, yes. So
Anyone can describe this ultrasound finding?
This is basically a thinned endometrium. And since the DNC procedure has been done, so every thin endometrium, we should suspect a uterine synecdoche, if it is proven otherwise. Because thin endometrium is mostly associated with the synecdoche.
Right. Supriya ma'am, would you like to
Can you
comment
please
on that?
run the video once more, please?
Yeah.
It is patchy also because in the fundal
Right.
part it is somewhat
Fundal
somewhat
part
thickened,
is not,
and when it goes to the body and lower down, it is somewhat patchy. So thickness you can measure that, but it is patchy,
It's a irregular endometrium.
irregular
This is-
endometrium.
Supriya ma'am, would you like to add on this?
I quite agree with what's been said. Only I see this hyperechoic area, which makes me think of a synecdoche.
Right.
And I
This
would,
the
I mean, since I'm
overline
more into
either-
ultrasound, since I have my leanings of AITA, I will just go by what terminologies they use to describe.
Right.
I have one question for Supriya ma'am. Ma'am, when we see this type of endometrium, it is patchy, then how to measure and how to report on the endometrial thickness? The maximum thickness we take or the minimum thickness we take to report for the...
Okay, one is endometrial thickness is always a maximum diameter in the anteroposterior plane. Agreed that Sonali can't display her images, so
Right.
she's showing us the clip. But in the image, if I were to show here, I would magnify it. I would only magnify the endometrium. I would decrease my gain, increase the contrast a little bit. So when I increase the contrast a little bit, I can see some border. If I can't see a border, as I said, I will write endometrium not well defined, hence approximate measurement. It is only one single measurement of the thickest part.
So, ma'am, we can see very beautiful synecdoche or this irregular endometrium on 3D also, but unfortunately, I am not able to.
No problem, it is visible in this also. It is very beautiful.
So there's no pathology in myometrium, so myometrium is showing better flow.
Normal.
No issues. So what next? What you would like to do?
Obviously,
This patient.
go for
Hysteroscopy.
look for the
Yeah.
endometrium. Look for the
Right.
cavity.
Right. It's more of a Asherman syndrome. So would like to do hysteroscopic adhesiolysis. So Dr. Shweta, how would you how would you like to do adhesiolysis, with scissors or with Polaris knife? What will be your preference? Dr. Shweta, you are not audible. Dr. Purva?
Hello.
Yeah.
Am I audible? Yes. Can you repeat the question?
Yeah. So you're suspecting that Asherman syndrome and Seineke. So how will you go for the hysteroscopic, with scissors? And what thing you will explain to the patient and attendant?
With we
With
can
scissors?
opt for either of the two. In this, you have used Collins knife.
Right. So it's better to use whole scissors, but if adhesions are very thick and very strong,
Then
Scissors,
scissors will break.
do it. You need 5-6 scissors for this. For this
It will break.
adhesiolysis. Always you can see I have used very minimal current, and very gradually I am moving forward to do this adhesiolysis. And
we have to be very cautious when we use this.
Exactly. And on laparoscopy, the tube was adherent because of previous cesarean or PID. So we did fibroplasty of that patient, and then we did the right tube was free, left tube was adherent with the pelvic wall. We did a adhesiolysis. This is a normal tube.
Whether she
We
was
always
evaluated
look
for tuberculosis, because Indian population, uterine
definitely.
Seineke.
Yeah. But
We should
history
go
is
for-
very significant. After
Uh-huh.
the DNC, she developed this
Typical Asherman.
Yeah. So now she's started menstruating, and tube was patent. Move on to our next question. A 32 years patient, married since 5 years, IVF conception and delivered full-term female fetus, full-term female baby 2 months back by cesarean section. Now complain of continuous bleeding PV on and off since 2 months. We did a ultrasound of this patient. So that is the picture of this patient on transvaginal. Can anybody describe the finding of ultrasound? And Dr. Purva?
Is the hyperechoic lesion is seen, small patchy lesions are seen in the endometrium.
Right. So here we can see
endometrium is irregular.
Irregular
Yes.
And
patchy.
it is patchy and with hyperechoic, linear hyperechoic.
Lesions are there, small.
But that they are also patchy. They are not just uniform
confined to
density.
Yes.
my 3D
The
pictures are not showing anything. So what do you think? What can be the differential diagnosis of this patient?
This patient, the
It can
history
be-
is very short. The
Only
history,
2
can you
months.
please just display the history of this patient once again, please?
Yeah, she delivered by cesarean section 2 months back.
2 months back
Then
only.
complain
So
of continuous-
retained products can be one of the differentials.
Retained products or causing endometritis and
Endometritis.
the changes.
Supriya ma'am, would you like to add on this? On this ultrasound? Ma'am, you are not audible.
Yes.
Hello.
You can't hear me?
Hello.
Can you hear me?
Yes, ma'am.
Yeah, I still said that hyperechoic area there is showing shadowing. Normally, any hyperechoic area showing shadowing is either very intense fibrosis or a calcification. So I would describe this endometrium as, again, and I'll measure the thickness, and I'll say, I mean, from what I can make out from the clip, endometrium appears heterogeneous in the upper part, hyperechoic areas showing shadowing seen in the lower part. Again, I would think of Sine K. And does she have any history of any IUCD?
No, ma'am.
No.
She is
And
giving history of on and off bleeding for last 2 months. Since her childbirth, she is
After
having
delivery.
yeah, so
bleeding.
any abnormality I've got at one color. Color Doppler. What are the color findings?
Ma'am, it's like not displaying. It was
No,
normal.
no,
Like
just tell us, it's okay.
non-vascular. This mass is non-vascular. So most probably it's maybe retained products which has been calcified, or it converted to osseous metaplasia of endometrium, which can be just a missing. On hysteroscopy, I directly jump to because I'm not able to open my 3D and other pictures. This was the finding. We can see this calcified spicules of maybe retained products, this hyperechoic, which is showing on ultrasound, and some retained products here and there, and some calcification. There's a ostia, you can see, and all over endometrium, there was a bits of calcified patches. Maybe retained products. There's the nodule which we'll see on ultrasound. So
all your differential diagnosis, we can go one by one and just exclude key if it is there or not. We can exclude them by exclusion key, what it can be.
right,
Retained fetal bones.
It's
Retained
not a
fetal
fetal
bones
bone.
is very
Bones we see clearly on ultrasound also. It's fasting
after
shadow,
it is
and
after abortion usually, not after
not
putting a
after the
vagina.
delivery. So most probably retained products.
Yes,
Say bits
exactly.
of placenta and converted to
And
osseous
converts
metaplasia.
calcified, they become
Or
calcified.
maybe
Endometritis.
retained products causing endometritis and then osseous metaplasia. It can also be the sequence.
That's what
in this patient.
So it was showing chronic endometritis with calcification. Sure. So move on to our next question. This 55 years patient came with the complaint of postmenopausal bleeding since 15 days. Previous 4 FTND, menopause since 5 years. Ultrasound pictures are not showing. Not able to display anything from this.
You can go for the video directly.
The video can
Meanwhile, I would just like to.
It was very interesting case. Just
It is very good, Sonali, that you save all the pictures, images, and videos.
right.
It is a very huge task, and it is satisfying also when you look back and see your images and videos.
Yes.
And correlate.
So I just wanted to show, and I would like to ask if Dr. Battiston or Dr. Kalpana is there.
Yes, ma'am.
Yeah. So this was the ultrasound picture. Can you describe this ultrasound picture of this postmenopausal patient?
Yeah.
Can you see
Looks
my
like,
screen?
Yes, I can see, ma'am. I can see. Looks like fluid in the cavity with some with some space occupying lesion in the cavity itself, arising from the posterior wall of the uterus.
Anterior wall.
Anterior wall,
Bladder
yeah,
is here.
yes, anterior wall, and it looked broad based. It's not pedunculated, and the fluid is covering the entire endometrial cavity. So I think right up to the cervix also. So that's all I can. Yeah.
Yeah, Dr.
the mass
Kalpana,
is
would you? Yeah. Dr. Kalpana is there? So this
Yes.
is definitely. Hello.
Yes, it's the whole of the endometrial cavity is filled with fluid, and it's a
Right.
large mass covering. The 3D picture was also there, na? Yeah, it's a
Right.
large mass, sessile mass, I would say, without the stalk, and the whole endometrial cavity is filled with fluid.
Right. So I just purposely wanted to show this picture because it is low level anechoic fluid, and this mass is very irregular margins, and she's postmenopausal, arising from anterior wall and with fluid around it, and we can see very irregular margins in this patient.
Yeah.
So now this is the color picture of this patient. So which is showing high grade 3 and 4 color score. Most probably this is the spot diagnosis of endometrial carcinoma. As we can see, all the feature of malignancy is there. So this shows suspicion of malignancy. Then we did hysterectomy with panhysterectomy with lymphadenopathies, lymphadenectomy. Move on to our next question. 46 years postmenopausal. This is done, I think. This is the same videos and picture of that same patient. I really extremely. No, this is a
different picture.
Different. So the next question was, patient was asymptomatic. She was not having any problem. She was having postmenopausal patient. She was having bone pain and back pain. For that, she was evaluated under orthopedic surgeon. Then on ultrasound, incidentally, they found some endometrial thickness to be say 15 mm. And then she was referred here. We did a histology. She was asymptomatic, no postmenopausal bleeding, nothing was there. She was hypertensive and diabetic. And this was the mass we find, which came as a benign polyp. We did a polypectomy, and definitely we'll keep her for the follow-up. So this is another patient. She's 27 years, married since 2 years, primary infertility with severe dysmenorrhea and menometrorrhagia since 1 year. DNC done outside somewhere else, but she was not relieved. And then she came here with the endometrium was thickened in the lower portion. So other infertility parameters were normal except the HSG, as patient was bleeding on and off. So HSG was not possible. So my question is how to manage this case, just having thickened endometrium, young age with continuous on and off bleeding PV, and what investigation further would you like to do?
Endometrium is thickened in this patient.
Yes.
We can go for SIS in this patient because we should rule out if there is any polyp or what, because
right,
she has
exactly.
history of infertility.
TAS, transabdominal. This was the mass in the lower segment. Here we are doing saline infusion sonography so that we can see delineation of this mass.
Yes.
And
It is very
this,
clear from this. It is a polyp.
yeah, this was a fibroid polyp because it is showing
The circumferential blood vessels picture can be seen.
this picture in this. So we did a hysteroscopic myomectomy of this patient. You can see this is the broad-based myoma, and we did a hysteroscopic myomectomy of this patient. So what all, Dr. Pattiston, would you like to tell what all precaution we should take while doing this hysteroscopic myomectomy? And what do you explain to a patient before taking it?
So before taking her in, we would explain to her about the location and the size of the polyp, and we will also take a consent that there may be a need for a second sitting or multiple sittings to remove the entire polyp, and there may be chance of uterine perforation, but probably it will be very less if we take a lot of precautions not to overcut the polyp while using the resectoscope. And we can use GnRH agonist 3 doses prior to the surgery to reduce the size and to make the surgery a little bit easier prior to the hysteroscopic resection.
Exactly. As she was bleeding very much, so we give a GnRH depot to control her, stop her bleeding, and we improve her hemoglobin. Then we took her and exactly pointed out it may require sometimes 2 sitting because lots of fluids are going inside. If there is a fluid imbalance, then we have to stop the procedure and we can ask her to come next. Sometimes this fibroid polyp are originating from the myometrial wall, and we are able to chop off the superficial part, and then after some time this came up in a subsequent ultrasound. So it can take 2 sittings. So these are all practical points we should keep in mind. This is the post-op picture of the same patient, which is showing.
So we have to explain about the chances of recurrence in this. That's what.
Sorry?
Chances of recurrence we have to explain. That's what.
Yeah, but I think recurrence is not that. But
like what? Yeah.
If you have not removed completely, then it can pop out further. Yeah. So this is the post-op picture, the differential of this patient. Move on to our next question. 31 years patient, previous to normal deliveries, 4 years back, came with a complaint of irregular frequent menses since 2 months. Parameter, all the profile was normal. No history of hypertension. So she didn't. This is the only history she gave, and this was the ultrasound. It is showing. Dr. Kalpana, would you like to describe the ultrasound finding?
The endometrium looks thickened and inhomogeneous, and there are few cystic spaces that I can see, but the endometrio-myometrial junction is maintained in this.
Right. So we can see here the mixed echogenic structure with the endometrial myometrial junction is well maintained in this patient. Then after seeing this ultrasound, I again ask her for any DNC or any history of pregnancy. Then she reveals 2 months back, she took some MTP pills and she was hiding all the history. And then she said, this is the color flow of this patient. Dr. Shikha?
Yes, so on color flow, it looks like a color score 3 or 4, more towards 4, because the color flow is involving the endometrial area also. So this looks like a case of retained products of conception, but the chances of bleeding will be higher during the procedure. Like if we go for a hysteroscopy also, the chances of the vascularity is high.
It is a hypervascular RPOC.
That's right.
Hypervascular RPOC.
Hypervascular RPOC.
Can anyone give me the
Count AVM
RPOC
also.
classification criteria?
Yeah,
For
so
RPOC, stage 1 is when it is confined into the endometrial cavity and it is homogeneous. It is hyperechoic. It is stage 1. And when it is heterogeneous and inside the cavity, it is 2. There is vascularity, which is the vascularity is started because this is stage 4 hypervascular RPOC. The vascularity is in the RPOC and as well as in the myometrium, it is increased.
Let's ask our expert today. Ma'am, Supriya ma'am.
Okay, I'm just saying the classifications now. As far as ultrasound goes, in order to help management, there are 2 ways of looking at it. One is, here it's very, very obvious against the history of taking MTP pills and it's a heterogeneous mass. This is what we call an endometrial mass. So the presence of an endometrial mass, how do you define an endometrial mass? Anything that bulges the borders of the endometrium. So that there is an endometrial mass, there is vascularity. Against a background of pregnancy, yes, this is an RPOC. But sometimes we are not able to decide, is it an RPOC or not? Now, there is one group which types it. So they compare the vascularity of whatever's inside the endometrium to the vascularity in the myometrium. So if the myometrium shows vascularity and the endometrium does not show vascularity, that's a type 0. If there is vascularity in the endometrium, which is the same as the myometrium, that's a type 1. If the endometrium vascularity inside is more than that of the myometrium, it is 3 and there's a 4 as well, I forgot. So type 0 and 1 or type 0 is most likely non-RPOC, it's a blood clot. Now, even if it's a blood clot or an avascular RPOC, I would think whatever little years I've spent as a clinician, really nothing to do because that will get expelled. Then the other way we look at classification from ultrasound is exactly how the IOTA classification is, which means they call it power Doppler. So there they use PDCS, power Doppler color score. So there it is 1, 2, 3, 4. Here we were talking about 0, 1, 2, 3. There's 1, 2, 3, 4. Right. And it is said that if it is color score 1 and 2, expected management will work very well. If it is color score 3 or 4, then expected management is most likely to fail. Now that Sonali has asked me, I will not.
So, ma'am, it's written like if it is 2 or 3, you just go hysteroscopically and then with the loop, you can remove the RPOCs. By chance it's bleeding, then you can simultaneously cauterize. It's better. So, my slides really. So this you can see on hysteroscopy, it's a RPOC mass. And I have not used electrocautery and I just use my forceps to dislodge it. But I kept my operative hysteroscopy besides me. If by chance it's bleeding or something like that, I could have cauterized this. This is a mass which everyone can appreciate, which is having the vascularity. This is my simple forceps. I grasp it from the base and I push it back. And I was able to remove completely without bleeding, nothing much.
Sonali, I'd like to say a few things. Sorry, no, complete after you complete.
This is the post-op picture. This is the both ostia and there's the place where the mass was attached. So it goes well. But we should have that electrocautery with us or electro loop with us so that while doing the curettage with hysteroscopic guided, you can cauterize that. So it was
missing. Wanted to say something.
Yes.
I want to say a couple of things. I want to ask some things as well. Now, what I want to say is, and I think we should be doing it because we all have come across this scenario. Every case of RPOC which we do for a scan, we should look out for something called enhanced myometrial vascularity. Now, if you've seen in the clip of Sonali's, if that clip was magnified, as she was sweeping, most of the time the EMJ looked regular, but at just one point we couldn't see the EMJ. And then exactly when we put color, we see vessels going, or rather color going from the endometrium to the myometrium. This is a feature of an enhanced myometrial vascularity. And I'm sure some of you will agree with me that maybe earlier on when ultrasound was not given so much of importance, when you took a case for RPOC for evacuation, you landed up with heavy bleeding and very, very unexpectedly. You landed with heavy bleeding because the fact that the presence of there is a presence of EMV was overlooked. So my point number one is every case of RPOC report, at least I insist and I do it, and I even tell the others who are with me that include a word EMV seen, EMV not seen. Enhanced mymetal vascularity noted, enhanced mymetal vascularity not noted. Now, if there is enhanced mymetal vascularity, earlier literature said we should go by the peak systolic velocity, but there is a more recent data from 2024 which says that we really don't need to look at peak systolic velocity. So what do we do in these cases? Again, point number one, this lady was bleeding, yes. But point number one is don't treat the scan. Only if the lady has a bleeding pattern out of normal. So what is a bleeding pattern out of normal? That at day 7, say after she's given medical pills, at day 7 there's very heavy bleeding. 2 weeks later there is persistent bleeding interspersed with heavy bleeding. 3 weeks later, just remember 1, 2, and 3. Actually, the 3 is 4. 4 weeks later, there is continued bleeding or persistent cramps or signs of infection. Only when you have a bleeding pattern like this, against a background of an ultrasound, will you do anything. If you see an EMV, we have to counsel the lady saying that most often this will resolve. This time to resolution can take anywhere from 2 weeks. Some have quoted 6 months, but I'm not fond of the literature which says 6 months. I would go by other authors which says 15 weeks or 3 months. So anywhere from 2 weeks to 3 months is the time to resolution. Most often it resolves in 1 month. If at all you have heavy bleeding in between, please report to the nearest setup that you are in. That's one. Second, I'm curious to know why do you want, I mean, I'm not a clinician at all, but I'm curious to know why are you doing a hysteroscopy for RPOC?
Because
I mean, okay,
sometimes these products are adherent to the endometrium. Sometimes you are not able to curate directly with the blind DNC. It's better you just see it and then remove it.
It is about the 3 and 4 variety, ma'am. When it is hypervascular, then there is chances of torrential bleeding. When we do it under vision, we can control the bleeding by
yes,
just
I would say
cauterizing
ultrasound guidance. So I'd say ultrasound guidance because not everybody will have the facility for hysteroscopy. And I would say that is more expensive and that's more of an invasive rather than ultrasound guidance. So regardless of what the nature of vascularity is, once you know there's an EMV, yes, you will take extra cautions to see that the uterus is contracting well. But as I said, I was just curious to know why you're using a hysteroscope instead of ultrasound guidance.
No, because most of the time the procedure is abandoned because of heavy bleeding. If it is not done under hysteroscopy guidance, we're not able to control the bleeding and we just put a balloon, tamponade, and blindly we stop the procedure. And most of the time it goes incomplete again.
No, that's heavy bleeding is because of the presence of EMV. That's why. Anyway, I think we will, I mean, if there are quite a few, I mean, as I said, it's nice to hear opinions. So there are quite a few still participants. Keep writing on your chat box what you use and let's, I mean, what is the methodology you follow if, and with reasons why. And let Sonali go on to her next case.
Yeah. Ma'am,
one point I want to add in this.
AVM, what is the difference?
Sorry?
AVM.
AVM is in the myometrium, na?
Purva wanted to say something.
Yes, ma'am, I just wanted to say that after removing RPOC or any products, we should, it is compulsory to send it for the HPE so that it can be very well differentiated later on also.
No, there are two things here. Because of medical MTP, we are, and then subsequent suction evacuation, at least as per popular guidelines, is really not the routine. So if there's a suction evacuation, yes, she should be sent for HP, mainly to rule out molar. If not, it is recommended that a beta HCG be done 4 weeks from the process of expulsion.
Yes, ma'am.
Yes,
to rule out molar and GTN.
Other pathologies.
So I think this is our
about
last
the AVM,
question.
Dr. Sonali, AVM was
Madam Supriya, ma'am.
Okay, earlier on, I mean, these are all, you know what, these are all my pet peeves, as you say.
Because AVM, na, we get the report of AVM very frequently. So
I'm 100%
AVM and refer to higher center.
Yeah, I'm 100% with you. that we do get reports, reports saying AVM.
Right.
Okay, now let me, it's like narrating a story. AVM is an arteriovenous malformation. It is a malformation. Therefore, in 2004, this term EMV was coined. And in 2015, all the stalwarts of gynae ultrasound, the world stalwarts, said that word AVM should not be used because it's a malformation. It is not a malformation. And if it is, it's a malformation that can only be proven in angiography. For that, embolization is the answer, and it is not a pregnancy-related birth. Then there was, a phase where they called it an acquired AVM. Acquired AVM is seen after any pregnancy event as well as malignancy. EMV is only related to an intrauterine pregnancy. If you report this as an AVM, she will be soon sent for an embolization, which is not needed at all. Therefore, the messages do not use the terms AVM because not an AVM. Do not even use the term acquired AVM. We are only using the term enhanced myometrial vascularity in relation to an intrauterine pregnancy. It could be a first trimester, second trimester, or the third trimester, which after expulsion, the placental bed or the future placental bed is not involuted, and therefore you get those future vessels still open, and that's why you get the bleeding when you don't, when not cognizant of the presence of EMV, and then do a suction or a curettage. So no more using the words AVM.
Ma'am, like if endometrium is thin and you have that AVM.
No. AVM is a malformation. It can occur anywhere from the head to the toe. It's the endometrial thickness. Endometrial thickness has got no bearing on the diagnosis of RPOC. Practically, they take a measurement of 10 millimeter, but you can get RPOC even with 5 millimeter. The only two things which will go in favor is it forms a mass, so the endometrium bulges out, and vascularity. That's all.
Okay. So probably this is our last. Dr. Kalpana, are you there?
Yes, I'm there.
Yeah. Can you describe this?
The ultrasound, it looks like there's a localized hyperechogenic patch lesion in the fundal area. It looks like a polyp, endometrial polyp.
So what is the best time to look for the polyp and menstrual cycle?
Priya ma'am has given
Day
the answer
10,
in a
day
talk.
10.
Very well
For
explained.
endometrial polyp, 10 to
In a
11.
proliferative phase.
Proliferative phase, triple line, yeah.
And we usually see for the feeder vessel.
Yeah.
In this, here we can see this is the single feeder vessel in this.
Yeah.
So there are many controversy when to advise polypectomy or not, and how it impacts the fertility. Can anybody, doctor,
Polypectomy? Yes, polypectomy can only should always be done if it is symptomatic, and if there is any history of infertility or any abnormal uterine bleeding. And this is hysteroscopic picture showing a small polyp, endometrial polyp arising from the with a stalk. It is a with a stalk. It is arising from the right lateral wall of the uterus, and it was well off taken care of.
So I have been to literature. Any polyp more than 15 mm should remove, or the position or location of the polyp is very important. If it is occluding the ostia or it's on the near the cornu, then definitely we should go for the polypectomy. So to conclude, transvaginal scan is the most
Sonali, may I add? Sorry.
Yes,
Yeah,
definitely.
in a polyp, yes, size matters, symptoms matter. If there are risk factors, if the risk factors for malignancy, age, high BMI, families of malignancy, polycystic ovarian syndrome, hypertension, diabetes, atypical glandular cells, polyp per se, if you're lucky and there has been fluid, or will be most well versed in SIS. If you do an SIS, you see an irregular outline to be removed. If you put Doppler and you see more than 4 or 5, there's a single vessel going on, but then that is multiple branches, or you see a scattered pattern inside the endometrium, then also you should remove, regardless of the size of the polyp.
Right. Actually, we were talking about the young patient with primary infertility. But you very well explained about each and every point of this polypectomy. So here we will conclude. TVS is the most commonly used and effective approach for detecting and diagnosing the uterine cavity and endometrial lesion. A structured ultrasound reporting system is required to help non-expert operator to more efficiently discriminate between benign and malignant uterine cavity. And we should all use EITA classification to for describing the endometrium pathology, as madam has taken in her lecture very beautifully. So I extremely thanks all my panelists, all Dr. Supriya ma'am as an expert being there for this wonderful discussion. And I keep all the practical scenarios in my presentation, in my panel, so that day-to-day queries we can take from this and apply in our practice. So thank you so much, everyone.
Thank you, Dr. Sonali. It was
Dr.
helpful and
Sonali,
informative.
Sorry, thank you again, but there is one question, Sonali. Would you want to address
In the
that?
chat box, yes, ma'am. It is
I'll
again about AVM, ma'am. AVM.
So I think Dr. Hita asked, can I repeat it? Sonali,
For
can
the
you repeat?
Ma'am, I cannot
AVM.
see.
Yes, ma'am, I can tell you that. What are the different criteria to define enhanced myometrial vascularity?
Okay, one is pregnancy. It's a pregnancy-related event. Number two, when we do a scan and when we do a sweep, there is a break in the endomyometrial junction. And at this break, we see they describe it as tubular serpentinous, like a snaky-like structure, which can be anechoic or hypoechoic, going from the endometrium to the myometrium. And when we put on color, the hallmark feature is this shows a lasing. A lasing means you don't get a pure blue or a red, you get a mixture of blue and a red. Now you might ask me, a mixture of a blue and a red may be due to technical factors. The setting is not right. So quickly, I will just tell you about the Doppler. When you see a lasing, look at the PRF. If your PRF is high, say 0.9, 1.2, then you know that it is indeed a high velocity flow. On the other hand, when you see a lasing and your PRF is just 0.3 or 0.4, it is more an error of the technique, what is called the Nyquist limit. There you will raise the PRF. So when you raise the PRF, say from 0.3 to 0.4, this lasing will disappear. So the message, when you see a lasing and there's a high PRF, then you're sure you're dealing with an enhanced myometrial vascularity.
Thank you so much, ma'am.
Right.
Just cleared all of the doubt about the thickened endometrium. And,
Yeah, I loved interacting with
endometrial
all of you as
abnormalities,
well.
ma'am.
Endometritis.
Thank you so much, ma'am.
I think we've covered all the questions. We cannot see any further.
One more question was
Criteria
there in the
enhanced
chat
myometrial
box about the, when you asked about that retained fetal bones, it was at that time, it was like subserosal
endometriosis.
what is the treatment for this? They have asked what about the treatment
Or
in
retained.
case of this.
If it is a retained fetal bone, or in this case, osseous metaplasia, we can remove hysteroscopically very well. And if there is endometritis, nothing else, then we can give extensive course of antibiotics, say for 21. I think that's a area, or hysteroscopically, you directly look and see and then treat.
One more small point I would like to add in that question. So we should also do beta HCG in a post full-term delivery patient when they come with bleeding, irregular bleeding after like 2 months, 3 months. So just to rule out GTN, beta HCG, doing beta HCG is a good point.
Yeah. So thank you so much, everyone, for joining us today and making this webinar a great success. So thank you, Bela madam. Thank you, Priya ma'am, and all our chief guests, guest of honor, and my wonderful audience and IFS technical team. Thank you so much for conducting it flawlessly. Thank you so much, everyone.
Thank you.
Thank you. Thank you.
Thank you.
Thanks. Bye.
Thank you.
Thank you.
Mr. Karan.